We are speaking with Dr. Gerald Tarnoff, Chief of the Children's Intensive Treatment Unit at Butler Hospital, about disruptive behavioral disorders. Dr. Tarnoff has over 30 years of experience working with children affected by these disorders, as well as their families. Dr. Tarnoff, thank you for taking the time to get together with us.
I'm happy to be here.
What can you tell us about disruptive behavioral disorders in children?
Well, disruptive behavior disorders can be categorized into really three different disorders. One is attention deficit hyperactivity disorder, the second is oppositional defiant disorder, and the third is conduct disorder. Let's begin with attention deficit disorder, or ADHD. ADHD occurs in about 3 to 5% of all children. Children with ADHD may have difficulties in three separate areas. One of which is their attention difficulties, the other is hyperactivity, and the third is impulsivity. Children with attention span difficulties typically are easily distracted. A child may often lose their school supplies, make careless mistakes, take a long time to do work despite their capabilities. They often do not finish their schoolwork, or they finish it and then forget it at home. The second component is hyperactivity. This describes children who always seem to be on the go. They have difficulties sitting in classrooms or just sitting without squirming around, getting up, fidgeting at home or at school. With impulsivity, the third aspect of ADHD, a child usually acts before they think. For example, they may blurt out answers in school when they're not supposed to, they have difficulty taking turns, are often impatient, and they may participate in more risk-taking behaviors. Not all children or adults with ADHD have all of these difficulties. Some may have difficulty with concentration or inattentiveness. Others may have hyperactivity and impulsivity together. Many also have difficulty with organizational skills. It's important to keep in mind that all children can show some of these traits in response to things that are going on in their lives or a particular crisis. In addition, some traits are developmentally appropriate. That's why it's important to remember that in ADHD, these symptoms typically start at a young age and are persistent. They will also occur in more than one setting, like at home and at school. And finally, to be considered a disorder, there must be some impairment, for example, in their schoolwork or socially. Now let's talk about oppositional defiant disorder, or ODD. All children may be oppositional at times, and oppositionality may, to some degree, be developmentally appropriate at certain ages. Oppositional defiant disorder, however, suggests an ongoing pattern of uncooperativeness, defiance, hostility, usually towards authority figures. These patterns also impair functioning and relationships. Children who are oppositionally defiant have frequent temper tantrums, they may argue incessantly, are easily annoyed, they often blame others for their mistakes, and they can be spiteful. Conduct disorder is the third of the disruptive behavior disorders. It is a diagnosis that refers to children or teenagers whose behavior is consistently troubling and clearly outside the range of normal and acceptable behavior. Often these youngsters show little remorse or guilt or concern about the damage or pain they may have inflicted on others. They are often physically or verbally aggressive and have a pattern of violating the basic rights of others. Bullying, threatening, fighting are common. Lying, breaking into homes or stores, running away, or legal difficulties are also often prevalent. There is a distinction of childhood onset conduct disorder, highlighting children 10 years and younger, or adolescent onset for those who are older than 10. Those younger than 10 tend to be aggressive and have fewer friends.
Dr. Tarnoff, how does a parent tell if their child might be just going through a phase or if they may really be suffering from one of these disorders?
Well, if it's a phase, it'll be temporary. Phases develop in response to a developmental challenge such as puberty or advancing in a grade in school, environmental changes, or a crisis. They should, however, get better in time. If it's just a phase, a child's basic strengths are basically preserved, and the relationships will remain important and meaningful if they have been before. Impulsive acts are more likely to be met with feelings of remorse or guilt, and at some point, a child attempts to resolve the behaviors that's causing those feelings. With any of these disorders, however, it's important to have a good evaluation to rule out undetected learning disabilities, depression, anxiety, a history of trauma, which may be associated with them. An evaluation will help to rule out other causes, whether they're environmental, psychological, or biological, or a combination of causes. Treatment is most successful when any of the underlying conditions are recognized and then treated. In addition, an improved understanding of what's really causing the behaviors may allow a shift in attitude, not only in the child, but also in the perception of others. While a diagnosis is not meant to be an excuse for a child's behavior, it helps everyone involved understand that the child needs some specific or specialized help, not, as some may perceive, just an attitude adjustment.
What are the most common treatments for these disorders?
Well, for ADHD, medications such as stimulants, while not the only treatment, can make a substantial difference in a child's life by helping them decrease their impulsivity, focus in class, and have better control over their behavior, allowing them to be more thoughtful. Other medications, such as 10X, clonidine, Strattera, can also be helpful. While there are no definite pharmacological treatments for oppositional defiant disorder or conduct disorder, treating any underlying or associated mood disorders, depression, anxiety disorders, as well as more subtle learning disabilities, speech and language difficulties helps. This can allow other treatments to be more effective. School-based interventions for learning disabilities, structured classrooms with behavioral-based interventions, smaller classrooms with behavioral and learning specialists also have been helpful. Finally, these disorders do not occur in a vacuum. Family interventions of various sorts, including family therapy, parent management, training programs, are often available. People should also consider individual therapies, such as cognitive behavioral therapy, problem-solving and social skills training, interpersonal therapy, or psychodynamic therapy.
Dr. Tarnoff, if a parent suspects that their child might be suffering from one of these disorders, what should they do?
Well, again, a comprehensive evaluation is necessary. The first place to start is with the child's pediatrician. This is generally the first clinician a parent can express their concerns to. A child's pediatrician already knows the child, can provide further direction. Other sources can be a child's school system or clergy if there's a religious affiliation. However, with symptoms that are severe or persistent, an evaluation, which will include a pediatric evaluation, a psychiatric evaluation, and possibly psychological testing, may be necessary to diagnose a child and develop a treatment plan. The local mental health centers also can be an available and valuable resource.